Hi, everybody. Welcome to GW Center for Integrative Medicine podcast. I have a very, very special guest today, our own Dr. Andrew Segal. She's going to talk to us about her new book. It's the book about John Sarno's. It's called Breaking Out of Pain, Leaving the Legacy of John E. Sarno. So we're going to talk about the book. We're going to talk about Dr. Segal's work. I'm going to give her introduction in a second. But before I do that, holidays are coming. Happy holidays, everybody. If you like our podcast, please do subscribe and visit our website at GWCIM.com. So Dr. Andrew Leonard Segal is a board-certified rheumatologist and is a clinical associate professor at GW in School of Medicine and Health Sciences. She graduated from the University of Michigan with distinctions from George Washington University School with distinctions in Alpha Omega Alpha Honorary Medical Society, which is the medical school equivalent of the Phi Beta Kappa. She then moved on to do residency in internal medicine at GW and then fellowship in rheumatology at Georgetown University Medical Center. She practiced general rheumatology and taught at Georgetown Rheumatology Fellowship Program for many years until she became interested in mind-body medicine in 1990. At that point, she decided to dedicate her clinical practice to treating patients with psychopsychologic disorders and moved the practice to the George Washington University Medical Center, which at that time was opening Center for Integrative Medicine. So we're talking about late 90s, more than 25 years ago. There she taught residents and medical students and became a Center for Integrative Medicine early practitioner. She started collaborating with Dr. Sarno in 1991 and then worked with him for a very long time. And Dr. Sarno trained Dr. Segal in TMS diagnosis. We're going to talk a lot about that today, so just hold tight. And over the years, he referred a lot of patients to her. He invited her to write a chapter in one of his seminal book called A Divided Mind. You can find that book on Amazon, and I'll make sure you have links to that. So we're very fortunate that Dr. Segal has been with Center for Integrative Medicine for decades. And in 2016, it was Dr. Segal's great honor to have been given the opportunity to make presentation at Columbia University Medical Center Psychosomatic Conference, Healing Unexpected Pain, paying tribute to Dr. Sarno's life and work achievement. And also Dr. Segal appeared in Dr. Sarno's documentary called The Rage. We actually featured this documentary at our own annual conference that's GW Integrative Medicine Office puts together. It's called it's a song symposium that's an annual event. And we had one of the events on treatment of chronic pain, and we also featured Dr. Sarno's The Rage movie at that time. Dr. Segal is widely published in peer-reviewed academic journals. She's skilled in clinical trial design, and she's worked for FDA for many, many years. She still works there, and she still works part-time at GW Center for Integrative Medicine. So give me a super great pleasure to welcome you, Dr. Segal, to our podcast. And let's just dive right in. Let's just dive right into the book. Yeah.
If it's okay though, first I'd just like to make a minor correction about
Sure.
the bio, if it's okay.
Sure.
I want to be clear that I graduated from GW Medical School. I graduated from the University of Michigan undergraduate.
Thank you.
And also, I'm no longer at the FDA. I consult in drug development in the other half of my life. So I just wanted to be sure that those two things were clear.
Thank you. Thank you so much. So your book, Dr. Sarno's Legacy, was just released on December 5th on Amazon. And it's currently #1 selling book in medicine and physiology. Congratulations, great achievement.
Apparently so. Thank you. Thank you.
Yeah. Tell us a little bit about the book.
Okay. Well, excuse me. I wrote this book with 3 psychologists that I have known for a very long time, who also have a very, very long history with Dr. Sarno. In fact, longer than mine. Theirs goes back to the 1970s. And We decided to write this book as a festschrift honoring Dr. Sarno for his extraordinary work, his visionary work, pioneering work in the understanding of chronic pain in many, many patients as a condition caused by psychological tension.
Mhm.
And chose to do it this year because this would have been the 100th year of his birth. He
Mhm.
died in 2017. And during the subsequent 6 years between 2017 and this year, we've seen some wonderful advances in the field of psychosomatic pain, in that there is a broadening interest in it. It is easier to obtain funding to study it. But we're also noticing that some of the people involved in the work seem to forget about Dr. Sarno's incredible contribution to this field. And no one doing this work today would be able to do it without his wonderful visions, his extraordinary observational talents, and his bravery for doing something that was a little bit different back then. And
Mhm.
you know, as a physician, I know as a physician that when you do something that's just a little bit different, it takes courage because a lot of people don't understand it. And certainly in this field, there are a lot of people that do not understand the relationship between the mind and the body and sometimes even scoff at it. So we decided that we wanted to write this book because although Dr. Sarno had written 4 books, and you mentioned one of them that I have a chapter in, um, he never talked about himself really and his discovery and how he taught other people and how he worked with other people. In fact, I saw someone recently write something that was disparaging, in that it said that he was an isolationist, and that couldn't have been farther from the truth. And it just was disturbing to the authors of this book because he was such a wonderful teacher and so welcoming of anyone who showed any glimmer of interest in the work, and wrote so many books.
Mhm.
And it was just such a misinterpretation. And so we decided we needed to do something to place his fundamental work in the history of this condition since the 1970s. So that was the purpose of the book. It's not a big book. It's a book of essays that each of us has written, and but we hope that it captures for people the essence of him and who he was and how his work is contributing to the future.
Mhm. Let me read what Dr. Andrew Weil, our good friend and founder of University of Arizona Andrew Weil Center for Integrative Medicine, wrote about your book. Dr. Sarno's seminal contribution to the field of mind-body medicine are duly honored in this collection of essays commemorating his 100th birthday. I have been impressed by Dr. Sarno's work for decades. Fortunately, the impact of his ideas persists in a recent paradigm shift in the mainstream understanding and treating of chronic pain. So I think it's a good time for us to talk a little bit about that. So John coined this whole term TMS, tension myositis syndrome, and he was basically the kind of the founder and the lead to say, look, there's a dramatic connection between the pain and this whole psychosomatic field and stressors. And the way he positioned it was so clinically relevant that until today, I still have patients. Sometimes I would, before they even can come to see you, I know you're very busy and it's not so easy to get to see, for patients to get into to see you. But sometimes we just give patients John's book and they will get like 50% better just by reading the book. So critical legacy, you have a lot of essays about him, but let's talk a little bit about the actual contribution that he did. Tell us a little bit about TMS. Tell us a little bit about sort of how he taught you and how he worked with patients.
Well, I guess that it would be helpful if I mentioned how he actually made his discovery. I like to talk about John as a modern day Darwin. He looked at something that was there and was sort of obvious, but not seen. And he had the intelligence and the curiosity to actually see it. And it started with two patients. He was directing, I will just mention that he had a background in family medicine. He was a trained pediatrician. And then he also did a residency in physical medicine and rehabilitation. And when he was directing the outpatient center at what is now called Rusk Rehabilitation at NYU Langone Medical Center in New York, he had two patients that had back pain, and they happened to have essentially the same anatomy when he looked at their x-rays. They had bone spurs in the same place, the same vertebrae were involved, they had the same kind of disc disease, and he had them in the same treatment program with same medications, same kinds of physical therapy. And one of them was getting better and the other one wasn't. And he's scratching his head and he's saying, why is this happening? And then it occurred to him that the difference between the two patients was that the one that was improving had the better relationship with him.
Mm.
And that was eye-opening in terms of, I apologize, there's a background noise here and
Oh,
it will
we
go
good.
away.
No, we good.
So, so I'm going to close the door. Excuse me for a second.
So while we're waiting
Okay.
for
Hopefully
that,
that will
okay, very
help.
good. Mhm.
I'm back. I'm
Okay.
so sorry. So after that, he started to look at patients differently, and he started observing them differently and started to become curious about who these patients were and wanted to study not just their physical presentations, but their psychological presentations. And as he got more and more into this, he called in psychologists to work with him. And the preeminent psychotherapist that he called in was one of the co-authors in the book. Her name is Dr. Arlene Feinblatt, and she's a brilliant woman, and she was very, very observant. And the two of them developed an inpatient program, which is something that one cannot do today, which lasted for 6 weeks. And these patients were coming in who were so incredibly disabled. They were coming in on gurneys and on wheelchairs, and they lived in the hospital having all different kinds of treatments, but also therapy sessions for 5 days out of the week. And through that process, they started to understand not just the common physical symptoms the patient but their common psychological profiles. And they found that people tended to be hypervigilant, worriers, tended towards perfectionism, suffered from low self-esteem, took criticism very much to heart. So it's certain characteristics like this, and they were all terribly, terribly fearful of their injury, purported injury, which in fact really wasn't injury, and their pain and what would make it worse. So this was sort of the essence of the discovery of the process. And now you asked me, there were a couple of things you asked me. What's the
Well, yeah,
next?
I mean, I think, is that when the term TMS came out of that inpatient work? At what point did it
Yes.
start? Yeah. So,
And he actually modified the name over time
mhm.
because tension myositis syndrome in clinical terminology really implied some kind of inflammatory process with the itis after the myo.
Mhm.
And he changed it to tension myoneural syndrome ultimately because he recognized that it was it was muscles and nerves that were involved in the process, but he also did work to try to figure out what the actual physiologic process was that
Mhm.
led people to develop these symptoms and was able to link it to the autonomic nervous system.
Something that we now actually understand quite a lot about. And I mean, I think subsequently there were a lot of research and a lot of people confirming John's work and basically saying, look, um, yeah, pain is subjective. You can, two same people with same anatomy can have completely two different experience of the pain. And then, when that started to become obvious, there were all kinds of potential treatments. But I think John was the first, right? I mean, he was the first who not just coined the actual diagnostic and therapeutic process, but he started widely using it and teaching it. I highly recommend for our listeners to watch the movie. I think the movie describes in a great detail actual process, and it's done in a very visual way with the person who actually had the experience and then cured is a wrong word here, just really resolved his pain through this work. So it's a very good way of not just seeing how it was done, but also seeing the experience of patients. You've been
I think
treating.
that I was going to say that I think that it's important for listeners to recognize that this diagnosis um, recognized that these people were in pain completely because of psychological tension that was manifesting in physical ways. And John's work predominantly focused on chronic musculoskeletal pain, common things like back pain, neck pain, different kinds of tendons that could be involved, that kind of thing, because he was a physiatrist. There are certain neurologic symptoms that people have that can be completely caused by psychological tension. But he also recognized that there is a broad variety of other kinds of medical conditions like irritable bowel syndrome and certain kinds of skin conditions like eczema or acne or urinary frequency or headaches, a whole variety, every organ system really can be involved in this process. And the key thing to know is that the process is completely psychologically induced and therefore can be completely resolved. So John did not manage pain. When one talks about managing pain,
Mhm.
that's not where this is. This is actually, as I'll use your word, reversing pain and making it completely go away and without the need for surgery or medications that can cause adverse events or other kinds of procedures. As a matter of fact, when he was in the outpatient division leading it at the Rusk Institute, he stopped using physical therapy for his patients because he decided that it gave the wrong message.
Mhm.
Why treat somebody with an exercise if the process really is about the brain and understanding emotions? And really, these these physical symptoms are all due to feelings, but frequently they're feelings that people actually aren't feeling. Frequently they're repressed anger, or as another one of the writers of the book, Dr. Eric Sherman, wrote about, there's something called affect intolerance, where a person can be feeling angry but feels horrible about themselves, can't stand the fact that they're feeling angry, say at their child, for example. That kind of anger can be intolerant to a parent. They can feel it, but they don't want to feel it.
Mhm.
And so that kind of emotional context can lead to physical symptoms, and all these emotions start up these physical symptoms as a distraction from those uncomfortable and painful feelings, as a defense against feeling them. So I think that that's an important thing for listeners to understand.
Yeah, and I just want to highlight one point. You know, he never, like, we're not talking that there's a sort of some kind of psychiatric condition that the patient is having. It's not like anybody's crazy. I think what we're trying to say is that internal stressors that are often not released, that are holding on inside, they're causing this. In essence, their actual causality here, it's not necessarily that, I mean, yes, the stress can cause inflammatory response and can worsen certain lesions or certain actual pathology, but we're talking about an actual pain being induced by this repressed holding on to stressors, if you will. That's probably a good word to use. And so when that gets released, I think the cure, when we use word cure, it's a little wrongly placed here, because it's really complete resolution of a problem. The cure implies that there's a pathology, and there is no
Correct.
biological pathology here. It is a pathology of our society, if you will, who doesn't help its peoples to learn how to basically handle those stressors. You'll go back thousands of years ago to native societies, and they all had ceremonies, they all had processes by which these issues would have been addressed in just cultural way of living. But we've, in a way, and I think John was one of the revolutionaries who recognized that this was lacking, so to speak, right? And I think that's why he invited psychologists to work with them, because they were the sort of people who knew this intuitively. So
I
talk a
think
little bit
that
about
is
that.
true.
Talk a little bit
Yeah, well,
about collaboration.
yeah, well, first, it's very important, something that you just brought up. These mechanisms of repressing feelings and having physical symptoms are normal, inherent human behavior. People are not crazy. And this stuff it's very important for people to understand that this is not all in their head, these physical symptoms.
Mhm.
This is an integration of how the mind and the body work together, and it's normal. It's just that when people have extraordinary stressors in their life and may have had um, issues in childhood that did not give them the tools to know how to deal with these stressors in a healthy manner, so that they were good at doing good self-care on an emotional basis, they're more prone to developing physical symptoms. But the beauty of this diagnosis is that with education and knowledge, and sometimes some psychological work if needed,
Mhm.
people gain those tools and can learn how not to become um, become a victim, I guess, of this scenario, um, and can be very healthy and can lead very normal physical lives. So I think that that was a very important point that you just brought up.
And I mean, John cured or resolved or reversed pain in thousands of patients. And I think there are also tens of thousands, if not hundreds of thousands, who just got better by reading his books, right? I mean,
Exactly. And that's the whole point. For some reason, knowledge cures this.
mhm,
And he never quite figured out how, what there was about the knowledge that made patients overcome their pain. Um, but it did. And a lot of that had to do with, I think, becoming unafraid
mhm.
of the symptoms. Knowing, because fear perpetuates them. The fear can become an obsession to people, and getting out of that loop
I think that's it. I
and
think that's the key. I think it's getting out of loop, because you go to any provider, any physician, right? And they're going to start looking for the cause of this pain being biologic, and they're going to find something. I have my favorite expression: you go into a butcher, you're not going to buy a salad. And and that's what's happening. I mean, look, they're gonna go to chronic pain clinic where it's all different procedures. That's how they make the money. And they're gonna find something. They're gonna get MRI on 50-year-old, and they're gonna find a lesion in the spine that may have absolutely nothing to do with the patient's pain, but they're still gonna try to inject. And that perpetuates this sort of the process of, okay, I have a biologic cause for my symptom, so we have to do something about it, versus this is exactly the reverse. It says, look, there is no biologic cause. Your cause is, you need to look inside and realize, what is that milieu of you? What is your personal holding on to that's causing this? And and that's knowledge, right? That's allowing yourself to look inside and say, okay, what's going on? And sometimes you don't need anybody. You just need to take stock of what's happening and go back inside to childhood, as you mentioned, and find something, and that's enough. And some people do need help, right? I mean, you work with a lot of patients, you know how it is.
I do. I do. And, I think it's important also as you're talking to bring out the fact that there are a lot of physical changes that don't mean anything.
Mm-hmm.
There are conditions that are important that truly do cause pain that are not this:
Sure.
cancer, infections, fractures. We can name things like this. But in my experience, having practiced general rheumatology before I got interested in this work, I think that the vast majority of reasons that people go to see a doctor are related to psychological tension, and it's unrecognized. And that is where the rabbit hole starts.
Right.
That is where, if one has a healthcare provider that's completely concrete in thinking physically and doesn't explore or understand or even entertain the idea that psychological symptoms can cause the physical complaints that people are having, then then people do end up in this. I've had so many patients come to me over the years who've had multiple back operations and haven't been better, multiple
And
neck
worse, right?
surgeries,
Often worse,
so have
because they're going to
gotten
start,
worse.
yeah, having complications
Exactly. And
surgery.
they're in this horrible loop, and they become more and more depressed. Some people become suicidal.
Mhm.
Um, some people feel that there is this concept of not knowing. I write about that in one of my chapters in the book. There was an article in the New England Journal just a year ago that talked about this concept of people that seek a diagnosis but can't get one.
Mhm.
And among that concept, we try, well, we think it's this, no, it wasn't that. Oh, we think it's this,
Mhm.
oh, it wasn't that. And this not knowing is just so distressing to people. And if the people taking care of them had some notion of the relationship between the mind and the body in terms of health, a lot of those diagnostic distress situations
Mhm.
could be evaporated. I mean,
Mhm.
I consider this to be really a healthcare um, disaster in this country,
Yeah, I
that
completely agree.
this process is not looked at. And
And
part of the problem,
let me interrupt you for a second. And it should be first thing to look at. Like, we go immediately jump at some biologic causality, not realizing that our thinking of that immediately shifts patient's perception, and it's already setting the wrong direction. And the whole system set up this way, right? So if instead you just say, okay, why don't we just first entertain idea of this that we're talking about, and then if that doesn't seem to help, or if there's a, then we'll do additional workup and we find something, sure. But most of the patients can probably save entire process of the whole x-rays, tests, a whole bunch of specialists completely by, and think about the cost savings here to society. Just the pain is right now one of the most prevalent. In fact, chronic back pain is the number one reason for general population going to physician's office. It's number one. It's the most common cause for visits to primary care providers. And, most of these patients, I don't know what percent. Do you know what percent of the roughly it's all of this? It's probably hard to estimate because nobody researched this enough, right?
But I believe that it's the vast majority. There, uh, most people with herniated discs don't need surgery. Most people will get better. John had a very interesting observation, another one, which he called the symptom imperative. And it's this round robining of symptoms. But I will mention that if somebody goes for back surgery, say that they have a herniated disc and they're having intractable pain, and somebody decides to operate on them, they get better. Maybe they needed the surgery, maybe they didn't, but they get better. Then a few months later, a year later, they no longer have the back pain, but they get neck pain.
Mm-hmm.
And people say, oh, well, it must be because you've been walking a little funny, because you're, working on your back. And having the surgery doesn't get people over the fear of the back. They always feel
Doesn't fix any
vulnerable.
psychological underlyings at all. In fact, it probably
Exactly.
makes them often worse because you're no longer even have now capacity to think, okay, well, that's where the problem is. You just you keep it in, everything keeps emphasizing there's a biological causality here, the actual pathology, and it's not.
So the assumption in that situation that I just brought up is that in essence, the pain is moved. The mind has found another site for the physical symptoms.
Right.
It could be the neck, it could be headaches, it could be a stomach ache, it could be a tendon, it could be the need to run to the bathroom all the time. And so this is the problem. It's a perpetuation. And when I wrote my chapter in The Divided Mind, I looked into the medical literature in pretty significant depth and found that there were very few studies on most modalities and even surgery that actually looked at, very few were large randomized controlled clinical trials. Very few of them really followed outcomes in a meaningful way. None of them, they looked, oh, we did this operation. Yes, the disc is gone. We did a good job. It's not there anymore. The patient is slowly getting better. There's an asymptotic relationship between how people do with surgery for a herniated disc versus not having it. And somewhere maybe 4 years out or so, they sort of reach the same point in their clinical presentation. But
there's a lot of data to say that you will do a sham surgery. Basically, you cut something open slightly, suture it back without doing it, and patients cure it from their pain. I mean, it's been done left and right for chronic back pain, and a lot of procedures, like there were certain different techniques or different procedures in orthopedics, like different inserts and all kinds of things. And a lot of them fell off because the moment they start doing a sham surgery as a placebo, not just no control, just like they realized none of this was all placebo. A lot of this is placebo, and these are the patients that they were operating on. There's, instead of wasting all these resources and pretending that we understand pathology underneath, they should have all been sent to John and John's practitioners.
The thing that is interesting about all of this, I, like so many millions of people in this country, had an episode of low back pain. And I went to see him as a patient. I because I couldn't figure out what was wrong, and I knew about him in New York. He had taken care of my aunt who lived in New York City, and he said, yeah, he said, this is what you have. And I had seen a couple of physicians in the DC area, and nobody had suggested that I had stress as a cause of my back pain. And yet I was a young doctor, a woman, at a time when there weren't very many female doctors, because I'm older than you are. And I had 3 children, and they were young, and I had a husband who was a physician working nonstop, and life was crazy. And I had no time for myself at all. And so I went to see him, and I thought, okay, yes, this just totally makes sense. It makes sense for my life. It makes sense for what I have going on anatomically here, because I had been imaged. Not much there. A bulging disc means nothing.
Mm-hmm.
And so I started working on getting better. And but I was struggling because I had this education as a rheumatologist that was devoid of any discussion of how the mind integrates with these kinds of situations. And I remember calling him back one day, and I said, I know this is it, but I'm struggling with it because, and he said, oh, you're going to have a terrible time getting better. He said, you have to undo
Yeah.
some of these years of learning to get, this is going to be harder for you. And he was right, it was. But when I started to recognize that it was okay to undo some of that, I got better. And I think that one of the difficult parts for physicians, if they get interested in this work, and the extreme bravery of Dr. Sarno in his work, was to learn that there are things that we have been taught that we have to pay a lot of attention to, that in fact are meaningless, and we're not taught that. And I remember when I was in training, and I remember one elderly woman in the emergency room, I think I wrote about this in the book, who came in with abdominal pain, and she had some x-rays of her belly, and her spine looked just degenerative as all can be. And I remember saying to her in the emergency room, is your back bothering you? Do you have back problems? Oh, no. So it goes to show how much change. And as a rheumatologist, I would see people with osteoarthritis in their hands, Heberden's and Bouchard's nodes, and
Mm-hmm.
they'd come in because their knee was hurting, or they had some other issue. And I'd ask about their hands, and, are you having pain? No, they really don't bother me. There's a tremendous amount of anatomical change that people can experience that doesn't have to cause symptoms. And so the challenge to the practitioner, and this, I face this every time I see a new patient,
Mm-hmm.
is to decide when the anatomy means something and when it doesn't. That's the challenge of diagnosing and treating TMS. But most practitioners don't present themselves with that question, with that
Well, it's
challenge when
not
they're
only
seeing.
that it's not only that they're not trained, they have no experience in doing this. This, what you just described, this capacity to know, is this particular finding on a test, on an image, or whatever, or just observing the patient, is it actually causing the symptoms? I think as a whole field of medicine, we're terrible at figuring this out, because it takes a lot of experience and, more importantly, an opening and capacity to stand in front of the patients who are suffering and say, wait a second, I know you think that this is what's going on, but how much are you sure? Like, is this really the reality here? And it's difficult, even I think for you and I. We've been doing this for quite a while, and we know that we need to ask this question every time. But even then, it's not all that trivial, especially when patients bring you, a suitcase of records of all kinds, and one doctor said this and one doctor said that, and everything is all over the place, and you're like, well, how do you consolidate all this? How do you consolidate all this? Like, so patient comes to see you in practice. Let's say they have the suitcase of the data that says, back pain, this and that, and surgery and this. What do you tell them? Like, how do you handle this, and how do you begin to this process of gradually shifting them to start looking at all of this completely differently?
Well, first of all, I tend to get a population of people that have sought me out because they have sort of come by, developed this interest on their own accord by reading. It's happened outside the medical system. I seldom get referrals from physicians like on the staff at GW or, across the community. I get referrals from other physicians across the country who do this work, who have a patient that calls them from DC, and maybe, then they refer them. But it's generally patient referrals or patients who have come to see me because they know someone who saw me. And the bulk of my time, first of all, they all come in and they're in a hurry. They want to tell me things really fast because they think that they only have 15 minutes to see me, or a half hour, because they're so used to the medical system. So the first thing that I do is I say, we have a lot of time. Take a breath, slow down. I'm going to listen, and I'm going to ask you questions, and I want you to tell me your story. And I just see them immediately sit back and they start to relax. And then I listen to their story. And as I'm listening, I ask a lot of questions about their social history. They first start with their medical complaints, and I want to hear all of that. But I spend a great deal of time, probably half the time, talking about their social history, not just what do you do for a living? Are you married? How many kids do you have? Do you have any hobbies? Not questions like that are yes and no, and the kinds of things that people generally get asked when they go to see a doctor. But tell me about your work. What's your supervisor like? How do you enjoy your job? How long have you been doing it? Have you thought about changing it ever? Or are you just, are you happy? Tell me about your family growing up. Oh, I had this perfect family growing up. Okay, well, tell me about your mom. Tell me about your dad. Did any of them ever get upset with you? What did they get upset with you about? These are the kinds of questions so that I really try to know who this patient is. And this is why a visit with me is an hour and 15 minutes.
Mhm.
I really take the time to know people so that I can start to make some connections if I can see them. Sometimes patients have a very difficult time describing their feelings, and I'll ask them how they're doing, and they'll say, well, I feel bad. Well, what does that mean? I say, well, I just feel bad. And Dr. Feinblatt talks about having to retrain people sometimes in language, the language of describing feelings.
Mhm.
She talks about it as going back to kindergarten, because sometimes people with these problems are not equipped with the vocabulary to be able to actually describe their emotions, or put a word on their emotions that actually conveys um, what is going on. So it takes time, and in the usual doctor's office, people don't necessarily have that time, but they can ask a few specific questions. Are you happy in your work? Are you happy in your marriage? Is there strife? There are things that people can ask that can give them a little bit of a clue in a short period of time.
Mm.
And I want to give a call out to the third author. I've mentioned the other two psychologists, but Dr. Fran Summer Anderson talks in her chapter about a patient that has chronic sympathetic activation, which means that she grew up in an environment where she was constantly feeling the need to be hyper vigilant, to protect herself in her environment because her growing up environment was scary and threatening. And what happens with patients is, we learn who we are, we become who we are when we're children. So many of the fundamentals of our emotional being start from childhood. And those compensatory mechanisms are very helpful to children in if they grow up in an angry household. Sometimes they sort of shy back. They don't want to rock the boat. They don't want to create trouble. They want to be invisible.
Mhm.
But if whatever those behaviors are move into adulthood, I say to my patients, everybody who's a kid wants to grow up, quote unquote. I want to be the boss of me, right?
Mhm.
But then they get up, they grow up, and they don't have the tools. They're still using the same tools that worked when they were unable to have a voice when they were younger because their household didn't give them one. They were unable to express an opinion because if it differed from what was expected, there was consequence for it of some kind that was not a pleasant one. But as an adult, that doesn't work. And so I consider TMS to be sort of that intersection between childhood and adulthood,
Mm.
even though this happens to people when they're middle-aged. It's the most common time for people to really get into trouble with this, although even though they've had symptoms maybe going on over
Mm.
previous years. But middle age is where everything crashes together. You got work, you got kids, you got elderly parents, you got responsibilities that you have to address. And the pressures of all of that, and people get lost in the middle. They just can't do any self-care. Um, anyway, those are just a couple of thoughts I guess I convey.
Yeah, we're running out of time soon. So before we sort of finalize, tell us a little bit about John himself. I think most of our listeners never met him. I mean, he's been gone now a few years and more than a few years. Um, I mean, I've only seen him once or twice, but I remember this sort of a sense of kindness around him and this sort of a capacity to just be with someone even though they're hurting. But you've spent a lot of time with him. Just tell us a little bit about him.
Well, first of all, he was he was all those things you say. He was very kind. He was very smart. He was very witty, funny. He had all these terrific phrases that he used to use with patients, to get them out of their fear. He would say, as far as I'm concerned, you can lift a 500-pound refrigerator. And that would get patients laughing. You know, he used to sing. When my husband and I went out to dinner with him and his wife, sometimes we'd be talking about something. He would break into song and it would be relevant to whatever we were
Mm.
talking about. He would say he was quite an accomplished musician. He played the piano and I've forgotten. I think it was the guitar. But one other instrument. He did it. He did this proficiently. He thought he was going to be a professional singer. I think when he
Wow.
was in college, and but but he was drafted, or I don't know if he maybe was called to service, I don't know, when he was in his late teens, early 20, to World War II. And he was part of a medic group that landed at Utah Beach in Normandy, and they went around helping soldiers. He actually was in at least one concentration camp, trying to provide medical care in Europe, and he spent a lot of time soothing and comforting dying soldiers. And this period, I think, is what motivated him to go to medical school. And so he was just absolutely terrific. He was very short, but he was such a big person. You know, his size, you didn't see it because his personality was so large. And he had a wonderful, wonderful voice, a terrific booming voice. And his office was very simple. It had a desk. It had a door to an exam room behind it. It had a bookcase. It had a telephone. It had a big window. No computer. And he looked at patients when he spoke with them. And
that's refreshing.
It really is refreshing. I try to make that happen when I see patients at the center. It's one reason why I actually do my notes afterwards. I take out a pen and I scribble, and I actually type the notes up afterwards, because I feel that in this work something is just lost if one is sitting there typing at a screen and is looking this way and the patient's this way, and it's so, yeah. But he was really an extraordinary person, and very kind, and very much for the underdog, very much for the underdog. So yeah, a real role model.
Well, thank you. Thank you. This was such a great review of him and TMS. And anything in the closing, any last words? Or maybe, how about this? If the patients think they may have this condition, of course they can come see you, but outside of that, like, what would you recommend? Like, what would be a useful thing for someone after, let's say, they read his book?
Okay. Well, if they read the book, one of them, there are 4, and if they get better, then they're in great shape. If they're still struggling, then I think it's important for them to get seen. First of all, you want to be sure that the diagnosis is correct. And my 3 psychotherapists that I work with in this book, and I've been working with them for years, all have such experience with this, and they're all very adamant about the fact that patients should not go directly to a psychotherapist. They should get a medical diagnosis first. Dr. Feinblatt says in the book, she writes, "I'm not trained to make the diagnosis. I know how to treat it, but she's not trained to make it." And so I think it's very important for people to recognize that a physician making the diagnosis for them is critical. And then if after that experience they're still struggling, then psychotherapy is good, and can make a huge difference. The vast majority of people don't need to go to psychotherapy, but I recommend that anybody that has suffered with pain for a while, or one of these other similar symptoms, the other alternatives. And there are psychological ones too, obsessive compulsive disorder, eating disorders. We didn't talk about any of that during our discussion. I think anyone can benefit from learning more about themselves. And sometimes people are afraid to do that, but that is, in my mind, a mistake, because there's so much to be gained from becoming more knowledgeable about oneself.
Well, thank you. Thank you. This is Dr. Andrew Segal, and co-author and a physician, co-author of the recent book that just came out, Breaking Out of Pain, Living the Legacy of John E. Sarno. You can find this book on Amazon. I'll make sure that we have all the links to all John's books in there. Of course, we'll have a link to Andrew, your bio on our website, and also I'll make sure that people know how to get in touch with you if they want to, or just schedule an appointment with you. I hope everybody have a good holidays, and remember that stressors can come at any moment, so it's important for us to always consider them even during holidays. So that's a good place to end. Thank you, Dr. Segal, so much for coming. Thank you.
Thank you very much, Misha, and happy holidays to you.